morning, everyone, and welcome. We're really glad you're here. We're going to get started in just a second. I just want to quickly review a few items. I'm Millie Sweeney. I'm with INTAC, and I'm with Fredla, and I'm here to moderate. I want to remind everybody of our commitment to maintaining a safe and accountable space. If you experience any issues or need any assistance, please reach out to me. You can send me a direct message. That's found at the top right corner of the event. To walk you through the tools in the session, I'd like to draw your attention to the vertical bar featuring several icons. It's on the right side of your screen. If your event feed is open, meaning that little newspaper thing at the top, those icons, if that is open, you'll need to close it because it's hiding your vertical bar that you're going to need for this session. So close that by clicking on, if it says feed, you want to click on the X in the corner. Once you've closed that, you should be able to see the vertical bar with several icons. You'll see speech squares, and those squares are the chat for the session. You want to make sure that you're chatting in this and not in the event feed. If you chat in the event feed, it goes to everybody that's attending today, not everybody here in this session. So you want to make sure that you do that. We do ask that you please use the Q&A feature. It's the little bubbles that say Q&A to ask any questions. The chat moves very, very fast. It's hard to keep up with questions that way, so please make sure that you put them in the Q&A. I'll try to catch any that are in the chat and move them there, but please do that. You can also vote for questions that are put in there if you're really interested in hearing the answer to a question. There's also an icon of people, and that indicates the participants in the session. And then the last one that we want you to pay attention to are the two papers that are stacked on top of each other. Those are all the resources from the presenter, including the slide deck for this session. So again, please use the Q&A, that is the third icon from the top, and the chat to interact with each other. If at any time during the session you feel like you need to step away or to take a break, to debrief or decompress, please feel free to do so. Our wellness room is open. You can enter the wellness room by clicking on the wellness room button on the top left side of the event navigation bar. A member of our team will meet you there. So it's now my pleasure to introduce, I'm not going to introduce all the speakers. I'm just going to turn it over to Rachel, and she will introduce the full team. So take it away.
Thank you so much, Millie, and thank you everyone for being here. It's been so neat watching the little ticker go up in the corner saying how many people are here in this session. We're very excited to be a part of this conference and to be able to share some information about our growing program with you, and then hear some of your perspectives as well. So again, my name is Rachel Reynolds. I'm the Assistant Director of Operations for the Virginia Mental Health Access Program. I've worked with this program since it started in 2018, and I have worked in nonprofit education and health-related programs for a little over 20 years. Joining me today is Julia Richardson. She is a licensed clinical social worker with Inova Health Systems in Northern Virginia. She had a crucial role in developing our first regional hub when we were just getting VMAP started. She does a lot of different things for our program, including education and serving as an LMHP for our northern region, and she's also the lead LMHP for our state program. And Kim Anderson is a lead care navigator with VMAP. She works out of Children's Hospital of Richmond at VCU, which is VMAP Central Region, and she's currently completing her master's degree in counseling. Kim's been with us as well since 2022. So with that, I'm going to get us started with a poll. So I am going to publish this poll. And we would love to see who is here today. So if you could respond to the poll in the comments, we'd love to know what role you represent in your program, whether you are a peer support navigator or coordinator, a clinician, a program administrator. If it's other, you can put that other in the chat and let us know what role you represent. Everybody's voting. Boy, it's going back and forth here. We've got a great mix of people. Not even slowing down. All right. So what a mix. Grant program manager, researcher, quite a few program administrators, quite a few clinical clinicians and peer support navigators. So that's great. It's lovely to see the great mix of people. Thank you for joining us. I'm going to close this poll. And here we go. All right. So with that, I'm going to turn it over to Julia, and she's going to tell you a little bit more about our program and why we're here.
Thank you, Rachel. So like she said, I'm a licensed clinical social worker. I'm a therapist, and I work with the VMAP program. I want to tell you about our program. We're very proud of it. And we also want to acknowledge right in the beginning that we are just one of many of these kind of programs, and I'll get to that and tell you about it. So listen out for things that might be relevant to your area and your state too, and maybe put some things in the chat about that if you notice similar things, or if you know statistics for your region as well, or how this applies to yours too. So we wanted to talk about nationwide, there's been an increase in pediatric mental health diagnoses. JAMA published in 2022 that just between 2016 and 2020, anxiety went up 29% and depression went up 27% in childhood diagnoses. So that's a lot. Between 3 and 17 years old, that's a really big increase. And we're seeing that play out across different places in schools, in their community. And one of those is in our primary care provider offices. Go for it, Rachel. When that gets to a primary care office, mostly those are pediatricians and pediatric primary care providers. They're trying to confront, address, diagnose, and treat that in their offices, and they're not behavioral health experts. The Virginia chapter of the American Academy of Pediatrics surveyed the state, and mostly these are pediatric serving primary care providers, and asked them if they had adequate resources for behavioral health for their patients when they got them in their office. And overwhelmingly, the answer was no. 95% said that they do not have adequate access to child psychiatry for their patients. 85% said that they do not have adequate access to other child mental health services for their patients. And 91% said that they could not exist with the existing resources. They could not meet the needs of children's mental health problems in their practice. And 98% said that when they need a consultation with a psychiatric provider, they could not get one to talk about one of their pediatric patients and help them care for them in the best way that they can. Go for it, Rachel. We know that that's partially because of a tremendous workforce shortage. This is affecting our whole country, but in the state of Virginia, we have an especially bad problem with our workforce shortage. We don't have enough psychiatrists, therapists, or just in general, pediatric mental health providers. 91% of Virginia localities are mental health professional shortage areas designated by HRSA in 2022. So that means only 9% of areas have, for the population, adequate numbers of providers. There's only 14 child and adolescent psychiatrists for every 100,000 children in Virginia. And over 65% of pediatricians said that they lack the training, knowledge, and skills in pediatric mental health and behavioral health that they need. That was in 2017. So our program came from that need to expand the capabilities of primary care providers treating kids and adolescents, and to expand the workforce a little bit and acknowledge that it's happening already, that they're leaning into that, and primary care providers are taking care of kids' behavioral health. In fact, we know that that's true with children and adults. Most behavioral health care is happening in the primary care office. There are many other programs. Ours was, I think, the 44th program that HRSA funded nationwide. the Human Resources and Services Administration, that we commonly call HRSA, has money that started our program, and we wrote a grant for it and got money for it. And then you can see all these other here. The dark blue ones are HRSA funded and receiving expansion funding from their state budgets too. The checker marked ones, I think, are HRSA funded only. So you can see we're in really good company now. Almost all states and territories, including some like the Virgin Islands and Puerto Rico, have these pediatric mental health access programs. So I encourage you to look up and see what you have in your area too. Go forward, Rachel. In our program, we found that there's two main areas that we needed to address primary care providers. We needed to address their capacity in a bigger picture, so education. So improving their ability to understand behavioral health on many different levels: early childhood, young childhood, adolescent, and young adult. And that's different levels: screening, assessment, detection of mental health earlier, treatment of it, and then referral, knowing how and when to refer to other kinds of treatment and having some sophistication with that, having some relationships. So that we cover under provider education. We have several different programs that are kind of different levels of intensity and commitment for providers. Our reach is really intensive, 3-day training followed by every other week phone calls for providers. They call that a mini fellowship, just focused on pediatric mental health. Our echoes are once a month lectures that are like lunchtime with the same cohort of learners. And our Pearls and Pitfalls series is an on-demand it's done about once a month, but it's not, you don't have to sign up for the whole series. You just do one lecture at a time. These are topic-based lectures. And our guidebook is a really great resource that anybody can use online, published for free, that's very clinically focused and guides primary care providers through what to do with all different kinds of presenting pediatric mental health problems. And then we also established the consultation line after we started education. The consultation line is what Rachel was saying I got to work on in 2020, and it's where we started a phone line where primary care providers could call in and talk to us about what was going on in their office and get help immediately, and consultation and advice specifically for one patient at a time, or generally about a topic or an issue. Mostly it's about a specific patient. We've got on our line mostly developmental pediatricians, child psychiatrists, licensed mental health people. We've got a team of care navigators who are experts at navigating families to behavioral health resources. And that's everything 0 to 22. So imagine like everything that you know of for really young little kids, as well as adolescents and young adults, knowing all the resources that are available and could be needed across levels of care. Move forward. This is how ideally we've envisioned the whole system working together for VMAP, that we do education that improves capacity in the primary care world, that they're identifying more problems, they're stabilizing kids so that there's less need for really higher levels of care and advanced use of the mental health system, and that they're calling us when there's problems or when there's more complex issues presenting in their offices, and that we're getting kids referred into the right kind of treatment in a timely way, reducing the time to treat so that they're not trying something else and then getting referred from a primary care provider to a generalist mental health provider to a specialist mental health provider. They're getting right into the correct evidence-based kind of treatment and effectively getting treated better and back out into the world, reducing the number of days and amount of time in the behavioral health treatment kind of side. And go forward. We've created partnerships all across our state. Our state, like many of them across our country, is really diverse. We have very rural areas, we have very urban areas, and very different kinds of urban areas. So our program is partnered with all of the biggest mental health, pediatric mental health serving institutions that were already doing this work in each region. And we've created hubs of teams that live and work in each region. So we've recruited child psychiatrists, developmental pediatricians, social workers like myself, care navigators like Kim, who already were living and working in these regions, who know the resources and limitations, the practical things of what's available, what's not available, and can answer these calls and do the care navigation and training for each region. Go forward. On our care navigation team, we have a really cool group of people. We've got 10 care navigators who are full-time statewide, so they are only providing help to families and young adults directly, finding those behavioral health resources. 2 of them are fluent in Spanish, one's an early childhood specialist. They're all identifying as female and women right now, and 40% of them identify as people of color. The experience that they bring is tremendous. They all have their own background in terms of being parents, having prior experiences working in the schools in early intervention or in mental health and social services or community services, family partnership work, special experiences in military and government and adoption work. So there's a lot of different specialized experiences that they bring that help them partner with different kinds of families, and that we use internally as a resource. When we get a family and we want their expertise, everybody kind of knows who to ask those questions to. Go forward. Our call line has just grown tremendously since we started. In 2019, it was just 100 calls, and then in 2020, just blew up. That's where we really opened it statewide and started advertising and doing lots of outreach. From then, it's grown tremendously. In the last 3 months, just this year in 2024, we've surpassed, each month has surpassed the prior month, which each month has set a new monthly total biggest goal average ever, highest number of calls ever. So we just continue to grow, and the need is there. And our education has also grown and become more detailed and focus on special populations as we hear from primary care providers what they need. So focusing on early childhood topics, focusing on young adults and adolescent topics, really listening to what we're hearing on the phone lines and what we're hearing feedback from in our education and providing that to the community. Go forward. Now we have a fun poll. Go ahead, Rachel.
So we're going to do another poll. So we would like to know a little bit more about what are the qualifications for maybe the programs that you work in for that role. Do you require them to have clinical experience, non-clinical experience? Do you focus on lived experience? This is a check all that apply. So the poll is open. You can vote. Love to see your responses. And wow, all three areas are kind of running neck and neck. I know it's a check all that apply, but it's almost 30-some% across the board with everything. So I think that's really exciting how much especially valued lived experience and that non-clinical experience is. And I think that leads really well into the next part where we're going to talk a little bit more about the experiences of our navigators and how we've seen this work in our program.
Yeah, so as Julia said, our care navigation has kind of just blown up over the past few years, and our primary care providers are finding so much value in this service. So we kind of wanted to tell you a little bit more about like how we approach care navigation at the Virginia Mental Health Access Program. So when we first get a call, we are getting all that good information from our primary care providers, and then we are kind of assessing like where this family is or what the family's needs are. One thing that's unique about VMAP is that when we take a case or a referral, we're not just immediately going into resources. We are linking with child psychiatrists, our licensed mental health providers, to help this primary care provider understand what's going on with the family so that we can match them with the resources that best serve them. So we kind of take like a systems of care approach. We're not necessarily just focused on providing those resources. We are always evaluating what needs to happen and who we can reach out to serve the family best. So oftentimes if that primary care provider calls and they do consult with one of our licensed mental health providers, we as care navigators, we take that information and we take those consultation notes to see what was recommended and to see where the family needs to go and what resources to provide. We also kind of use our own experience when talking with families. We help we lean on one another in our individual experiences. So, for example, I have a colleague who has experience within the judicial system. If I have a case where there's a family that is involved in the judicial system and I'm kind of like, I'm not really sure how to help them, I'm going to lean on my coworker and ask them for assistance. And so when we approach these cases, we're not necessarily just, saying, okay, this is what you need, this is what was identified. We're really trying to tap into that lived experience and to paint a bigger picture of the needs and address them how the family needs them. Also, something that's unique about our program is we take the information that our families and our primary care providers give us, and we actually go back to like licensed mental health providers in the community or agencies in the community and tell them what we're seeing. So each of our regions have advisory committees, and we meet quarterly, and we just kind of update them on what's going on and what we're seeing. For example, recently we had a family or we had several families that were getting into care, but care wasn't being completed. So they were getting that initial assessment, but there was no consistent follow-up. And so we went to our providers and the agencies and we said, hey, we're seeing this. And they actually were able to give us amazing feedback on why it might be happening. And that allowed us to prepare before we talk to families about resources and help mitigate some of those issues and explain to families what barrier might come up and how they can move to the next slide. Thank you. And as care navigators, we have a family-led and person-centered belief, and we use the motivational interviewing spirit to kind of address that belief. So when we are calling and speaking with our families, we trust that they know what's going on. We trust that they know what's best for their kids, and we listen to their lived experiences. Because we have two families coming to us for the same service, like let's say they're both looking for intensive in-home, that doesn't mean that we're going to approach the case the exact same way for both of those families. They have different barriers, different expectations, and different needs. And so we are always listening to them and letting them guide what our next steps are. And, we also believe that they are capable of accomplishing their goals. So, for example, if they are looking for outpatient therapy, we trust that that's what they want, and that if that's really what they want and what they need, then they're going to be able to meet that, to go to therapy and to complete therapy. I think when we are working with primary care providers, they don't have a lot of time with families. And so a lot of that feedback to families can be very prescriptive. And so whenever we receive a referral, we want to make sure that we are listening to the families and that they understand that this referral wasn't made because, the primary care provider just thought, this is what's best and this is what you should do. This is about helping the family meet and achieve their goals and what they think is best for them. And something that we have to navigate often as care navigators and as VMAP as a whole is we have primary care providers that will call and they will say, hey, our family needs outpatient therapy. And then they talk more with our licensed mental health provider, or we're talking more with them on the phone. We're like, hey, I don't know that outpatient therapy would adequately address the situation. And the primary care provider oftentimes is only recommending outpatient therapy because they don't know what else exists. And a part of the reason of that is because, Rachel, you can go ahead and go to the next slide, is that there's so much that happens in between outpatient therapy and those inpatient crisis stabilization unit levels of care, but they're not necessarily available within our communities. So they're not aware that they exist. And part of our role as VMAP is to educate our primary care providers on these other levels of care and help them understand how we get how our patients move through it. So for example, if I have a family that calls, or sorry, a primary care provider that calls and they're telling me, oh, I think our family needs outpatient therapy. The patient is exhibiting like some of these more extreme behaviors, I'm going to say, hey, maybe you should talk with Julia, our licensed mental health provider. And then she can kind of educate them on, oh no, what this patient really needs is intensive outpatient, or maybe they even need some more inpatient care. Another thing is that as we have these levels, each state and locality, they have different requirements to care. So for example, intensive in-home in the state of Virginia, you have to be at risk of being displaced. What does that mean? That can mean many different things. But if I'm talking to a family and they need intensive in-home, it's my role as a care navigator to make sure that they're able to adequately communicate that to the intake coordinator when they call, because sometimes they'll call and they'll get an assessment, or what someone says, oh, maybe you don't qualify for this. So it's also our job as care navigators to kind of help the family understand that, and also what's required of the family. Outpatient therapy is just once a week, but if it's intensive in-home or applied behavioral analysis, they're going to be spending more time. So that's kind of where we come into this. And when we first receive a case, the kind of going back to that family-led and person-centered approach, the first thing we do is we reach out to the family. Clean slate. We know what the recommendation is. We know a little bit of the background information, but we're reaching out to them to kind of see what's going on, to see what they need. So we're establishing a relationship with them. It's not just like a cut and dry situation where we call and we just pass off some information. We really want to be a part of their care journey and walk alongside of them. So we're establishing that relationship, and we're gathering information about what's going on. Oftentimes, again, going back to that primary care provider, they only have a certain amount of time with this family, so they might not have been able to communicate all their needs or everything that's going on. So this call is really important to know that. And also the family might have questions about the services that are being provided. So we give them that information and help them there as well. So after we've gathered that information, we start providing resources. So again, we reach out to our colleagues. We call the resources. We make sure that appointments are available. We make sure that they take their insurance, or that they are within driving distance, or if it's virtual, we make sure that all of those things are there before providing those resources. And then we also provide that back to the primary care provider so they know what was recommended. And then in our next step would be to follow up with a family. And this is where a lot of the magic of care navigation happens, because as we're establishing that rapport, we're learning what the family is going through and what barriers they have. They might not have been able to communicate them in the beginning, or their situations might have changed. So a lot of times we are, helping them navigate those barriers to mental health care. Sometimes it's other things, like we can't really meet the mental health need unless we have those other basic needs met. And so we can help families navigate those as well. And in the middle of all this, we are preventing families from escalating to that need of higher level of care. And then when we close out a case, we don't have a specific amount of time that we have a case open for. We really let our families guide when they need us and when they don't need us. So as we're following up, if the family says, hey, we were able to get an appointment, I think we're good, then we're like, great. And then we close out the case. If the family says, hey, we have some appointments, but, you know, I'm really don't know what's next, I would love for you to continue to reach out and talk with me and make sure that we're happy with the care that we're getting, we will do that as well. Another thing to note is that even if we close a case, a family can always reach back out to us and ask for more help. And when we close that case, we are always communicating with the primary care provider the outcomes, what happened. You know, they were able to get an appointment with this agency for the state and things are going well. Or maybe it's the family said that they weren't interested in resources anymore because they have to move somewhere, or you know, or they have another family member that is in receiving critical healthcare from something else, like they're dealing with like an illness or just other things. We report that back to the primary care provider so that they have a better understanding of what's going on with the family and can follow up on those things in the future.
So this is going to be our last poll question, and we're actually going to ask you to go to the chat, not the Q&A, but the chat. And we'd like to just hear from you that if you work in a program, it sounds like a lot of you do, that provides these kinds of care navigation or coordination services, what are some of the barriers or challenges that you find make it difficult to direct families to resources? We're going to talk more about those barriers, and we know they're out there. So go ahead and put in the chat some of the things that you see as barriers or challenges to getting families to the right care at the right time. And we've got lack of resources and/or knowledge, lack of available resources in under-resourced counties, lack of availability, yet the programs have long waiting lists or are backed up, no clear navigation in the system of care, no one is sure where others should go and for what, families feeling overwhelmed, even with support. Absolutely. These are great examples. Thank you all for sharing. Limited workforce capacity, siloed resources, lack of follow-up with providers and families when referrals are made. These are great examples. Not full knowledge for covering diversified communities, limited clinicians, again, absolutely. Great, and if you think of other examples, you want to put those in the chat. Those are all like absolutely wonderful examples. Service deserts, yes, thank you for pointing that out, especially for intensive services. Language issues, yes, language access. So Kim's going to pick this back up and talk about some of the outcomes that we've seen and some of the barriers that we've also and challenges that we've experienced in our program.
Yeah, I'm reading the chat here, and you know, we have a lot of the similar experiences when trying to connect families with resources. When we think about our outcomes, so our outcomes here are for 2023. From a big picture perspective, as care navigators, more than 80% of the time, we were able to get the resources to the family. If we weren't able to get the resources to the family, it's often because, you know, we weren't able to make contact with them, or maybe they just weren't interested in services. But for the most part, they are, and we are able to give them those resources that they can take with them. And like you guys said, those barriers to care. For us, you know, these families don't just have mental health concerns going on. They have like multiple children, they have extended family. You know, we are in a very weird financial time as a country. So they have other things that they need to address before they can get to those mental health needs. And resource availability, I mean, I guess that's why our care navigators exist. maybe, and also something to note about resources availability is while one resource may work for a specific family, that doesn't mean that it works for another. So, resource availability is contingent on those like insurances, like Medicaid insurance, you have access to certain resources. And then if you have private insurance, you have access to certain resources. So that can, get a little tricky. But for the most part, I think when we think about providing, helping families navigate the system, it is the availability of resources because, we have a limited number of clinicians in certain areas and throughout the state. So we kind of see similar things that you guys are seeing in your communities. Yeah, and also those challenges, again, back to that is the family barriers, like what the family has capacity for in that moment in time and helping them navigate the needs that they have at that moment. And then hopefully we can eventually get to those mental health needs. And service gaps, community gaps, cultural gaps. I think someone in the chat said that, we just don't have clinicians that are diversified enough or have the knowledge to treat those special populations. That's so true. In my program, I can tell you that, I can see our social work programs and our counseling programs growing and trying to expand our knowledge and really putting forth the effort to meet those needs. But it's going to take a while for us to grow. Another thing that we see is sometimes the perception of the care navigator role is a bit, miscommunicated. Sometimes families or providers think that we can call and make appointments for them as care coordinators. Unfortunately, we don't do that. We don't make appointments. We can't, coordinate every single thing for the families, but we also kind of go back to that family-centered and motivational interviewing approach. And, our families can do these things and we can help them get there. And so that's how we kind of approach it as care navigators, because we just don't have that care coordination piece of it. Another thing is, we're not able to make contact with families all the time. It's kind of inconsistent. So we don't know where they end up. Do they get those services? Possibly, maybe not. We do our very best to, call them, text them, send out surveys, and ask if they were able to connect. But at the end of the day, we just don't have a lot of data in order to make accurate, predictions of what's going on.
So this concludes the core of our presentation, but I'm sure some of you have some questions, and we'd love to hear, just based on what you've already put in the chat. I think you've got some great perspectives from your own programs of seeing very similar themes. I did already see a couple of questions in the chat. There was a question about whether our care navigators are all clinical and how that care navigator LMHP dyad works in our program. So actually, I want to pass this over, and you all can keep putting questions in the Q&A section. But Julia, if you want to talk a little bit more about how the dynamic between the navigators and the LMHPs work together in each region.
Yeah, I think that's a great question, Rachel. And I always have to start by acknowledging that when we started doing care navigation, I did it, and I'm an LMHP, like I'm an LCSW. So when we started doing care navigation in most of our hubs, we started doing it as the clinicians. And that's part of how we started using our motivational interviewing perspective and being very family-centered and having a hopefully very supportive and empowering perspective and methodology of working with families. And I hope that that's how we've come to train and support our care navigators, is that we started doing it ourselves. So that's my personal background with it, is that really that's how we came to it, is I was doing care navigation too. And so as I added care navigators to my team, I continue to do some cases, and we work very closely to talk about what are we hearing from the families, role-playing difficult conversations. So saying like, this family's just, telling me that everything that I find for them isn't right and being very challenging. And so changing the mindset on that. Okay, well, have we elicited what they're hoping for? Have we focused, using our focusing skills to focus on one service or one symptom that we're hoping to improve, one thing that we're hoping for? So we do a lot of supervision every week. I meet with my care navigators in my region, and then we also meet regularly as a team of care navigators to talk about cases and to talk about our role and making sure that we are providing the best information to families. We've created handouts and information for parents to help them advocate for their kids within treatments. So knowing what to expect from psychiatry or what to expect from therapy, knowing that they should be getting a treatment plan, they should be getting discussions regularly with their therapist. So they go in with really good expectations. And then when we get a family asking for something or with questions about services like Kim alluded to, we are always there as a backup for the family. So if they're asking about why do I need this kind of treatment, or they're telling a care navigator some information that seems very high risk or concerning, we're always there as their backup to jump in and work with the family directly, and also to communicate very important information back to the primary care doctor. So occasionally I'll hear things like, oh, we stopped giving her that medication because it was making her really have a lot of side effects. And we'll say, well, did you tell your primary care doctor that, who's prescribing it? Oh, no. So we want to close that loop and make sure that we're letting them know that, because it could be dangerous to stop some of these medicines right without a taper. So things like that, sometimes we need to communicate back, and that's the role of the licensed mental health person. And also in our hub, we have a child and adolescent psychiatrist who's also available to our care navigators to talk about these kinds of things. It's not just the therapist. We also have our psychiatrists all integrated. So we're talking about what's evidence-based practice, but also what's available in our community and what's best for this particular case, because we know there's a difference between research and applying that to a particular individual family and child. So we're helping them the best that we can. And what else would you say about how we work together to kind of give the best of our perspectives and trainings to families?
Yeah, so I would say that, as we work a case and we work closely with the family, things come up a lot. Like whether the family's in crisis or something weird just isn't making sense to us. I go back to my LMHP a lot, and I'm like, hey, I got a lot of this information and I don't know what to do with it. Because I don't have clinical experience, and I think that's an important part of the care navigator role, is to know that we are not clinical. I think Rachel kind of mentioned that in a Q&A question, but we're not clinicians, and so we can't serve that role for families. And we got to know our limits, and that's when when things get kind of weird or we're unsure how to proceed, we will go back to our LMHP and say, hey, this is what I'm hearing, not really sure what to do with it. And that's where I find a lot of value in that role. Also, our LMHPs are just so amazing, and they have been embedded in a lot of different systems, mental health systems. And so they really do set us up for success when we are doing that initial care navigation resource list building. So like saying, hey, this is what the family needs, but maybe they could benefit from these other things as well. So I think that we work really well together. And I think that having the LMHP and our psychiatrist provides a lot of value to our families as well. So they're not getting stuck in this one specific level of care.
Another question that was put in the chat or in the Q&A, and I can address this, so is asking about how we build relationships with the pediatricians and doing training with them around mental health and family engagement. I think this is a great question, because as we started VMAP, as Julia presented, the need was obviously there. But the challenge is sometimes that resistance, pediatricians and not just pediatricians, but other primary care providers, they're trained as generalists. And so their training is all about learning how to refer. But the problem is they're never going to be able to refer adequately because of what we know are the workforce challenges and workforce challenges that are unique to mental health. And I think what we've learned, especially from our medical director, Dr. Sandy Chung, who is a pediatrician and has had great leadership in this area, is that when it comes to primary care providers, you can kind of think about them in terms of like thirds. So about a third of these providers really know that this is something that they need to address in their practice. They want to, they just need more training. They want to be able to do it. And so if you give them things like the VMAP line and the education opportunities, they're going to be jumping at it. They were our early adopters. They were the people who were like, thank you for having this program. I'm going to use it right now. And then we have another third that are like, I know I need to, but I don't know if I have the time, or I'm just not really sure how to do this. And so they're the ones where we've really used those early adopters as our greatest champions. And we've built on that success by being able to see how it works. I think some of the best people who are advocates for our program are the people who are using our program and have seen the success in their own practice. They go through a REACH training and they say, this absolutely changed the way I practice medicine and the way I operate my practice. And so then we work on, kind of building that third of the provider skills. And then there's a third, probably less than a third now, but there are a contingency of providers who are resistant to this, and they really still want to rely on that referral model. And so we're listening. We're trying to work with providers and be collaborative and figure out how that one of the biggest things we always ask ourselves in our program is how can we eliminate barriers to care? So we're often, providers don't have to register to call our line. We'd like them to, but they don't have to do that immediately. They don't have to have taken a training with us in order to call our line. So we want to make it as accessible as possible. And, sometimes Julie is even just out in the community at a conference and she'll talk to a provider and tell them what they need to know. So we try as much as possible to eliminate those barriers. And I think what's exciting is that we've really seen in the last 4 years or so of building our program, how impactful this can be for providers, and then building on that success. There's another question, and Julie, I might throw this one back to you, asking about pushback from primary care and wanting to speak with the psychiatrist. I think it's kind of interesting because sometimes we have to convince them that they need to speak with the psychiatrist instead of just asking for care navigation. So Julia, do you want to talk a little bit about that?
Yes. So often when someone first calls, they want to just talk to a psychiatrist and ask their real quick little question. The real quick little question is usually something like, can I prescribe this with that at the same time? And we know that there is not a black and white answer, because it depends is almost always the answer in behavioral health. We are very comfortable with gray areas and with applying rules across multiple situations. It's the same thing in prescribing. So psychiatrists are going to say, I need to know the age. I need to know their comorbidities. I need to know their diagnoses. I need to know how long they've been on these medications. I can't give you a quick answer on that, on a yes, no thing like that, unless it's egregious. And then I'm going to be like, no. So what they're going to say is I need to know all the case information to get a proper answer that's going to apply to your situation, your patient. If you want a general answer, I can give you that, but it's not going to be applicable to the answering the question that you want. So when we're getting someone who's calling the line and they're like, I just need to talk to the psychiatrist for a quick question, we'll say, is this general or is this about a specific patient? It's about a specific patient. Having all that demographic will help the psychiatrist to speak directly to your situation. And very rarely ever had somebody just insist that they will only talk to a psychiatrist. Keeping in mind that most of the calls are coming to us licensed mental health people, we are actually helping them define their questions. We are using very careful, our same clinical skills that we're always using. We're using very careful questioning to help them refine what their questions are, to help them build confidence in their questions, and then be ready for that consultation. We also have other ways for them to get the call from the psychiatrist to get the demographic information. So after they've called us the first time and they've said, oh, I don't have time for this 5-10 minute call to give you the demographics and then get the call back and connect with the psychiatrist, we'll say, okay, well, you can put a request in online on our website. You can send me a fax. there's other ways that you can get this demographic information to us, and we can just have the psychiatrist give you a call at this time or confirm at this time. And so we're trying to bridge that gap with them. Now, I also have to say it depends on where their prior expectation is, because if they're coming from a prior experience of having no access to any child psychiatrist, they're like, wow, it's amazing that I can get a call back within 10, 15 minutes from a child psychiatrist. That's awesome. I don't mind that I have to talk to you first, Julia. But if they're used to having people on speed dial, and now you're putting a barrier in between their access to those same people, which has been the case in one of our regions, then that's going to be a harder sell. So I will say it kind of depends on what their expectations are and kind of working within that. But I mean, that's kind of just our program. If they don't like it, they don't have to use that part of our program. Now, like Rachel was alluding to, after they start using our service a lot, then it tends to be the opposite. It tends to be, oh, I don't need to talk to the psychiatrist. I know what they need. They just need care navigation. I've got it. I'm doing all I need to do with screening, monitoring, medications. Got it. They just need care navigation to get this specific kind of evidence-based treatment that I already know they need. And we're like, wow, amazing. They use screeners, they're tracking treatment, they initiated medication. This is awesome. But wait a minute, something doesn't sound right. Maybe they're not making progress. Maybe something's off with something the family is saying. Maybe we want them to talk to a psychiatrist, and now we have to kind of talk them into it, or we're doing it on the back end where we're calling our psychiatrist colleague being like, hold on, can you review this case and what the family said? So it's a little bit of both ways. We're always trying to have a multidisciplinary look on every single case. So I generally say that in general, we don't ever want to have a kid or a family who comes through a VMAP consultation that only gets touched by a psychiatrist, care navigator, or LCSW, or licensed mental health person. In general, that they get the best of our program if they get multiple touches. So if they get at least two of us looking at their case and making sure that we're all, from a multidisciplinary perspective, agreeing on what's best for their kid. But that's
yeah. One of the questions is asking, what does the role look like for families with a child or adolescent that's hospitalized or has had multiple hospitalizations? So I know you've both managed cases along those lines, so I don't know who wants to speak to that one.
I can speak to it. I think it really depends where the family is at in the process. So we're not necessarily in crisis. Like, that's not our role as care navigator, is to get them into a hospital per se. If they're actively in crisis, our licensed mental health provider and our psychiatrists are involved. So we're not necessarily care navigators are not necessarily intervening at that acute moment. That being said, we will still work with them to get connected to resources when they need to leave the hospital, or if they're in the hospital, or sometimes the family members need resources navigating. I don't know, like they can't leave the hospital unless they have a psychiatrist appointment made. So that's where we kind of step in. If the patient has had multiple hospitalizations in the past, but they're not in that acute state right now, we will work with them as, we do all the other families. It's just, we're probably escalating it back up to our licensed mental health provider or a psychiatrist as needed. But that doesn't mean that we're not actively involved with the family. It's just, knowing our limits and what our role is, and when our role is not necessarily going to be beneficial for the family at a specific point in time.
I think I'll add a little bit to that, Kim. When we get kids that are high risk, meaning that they have a lot of hospitalizations, a lot of mental health need, we are doing the same thing that we would do for any other kid. We're hopefully bridging the gap between them not having behavioral health care and having behavioral health care, and then backing away. So if that means that they are getting into the hospital, then that's great. We're helping their primary care provider, referring them for hospitalization or for residential. And then we're deferring to their treating providers. If they're in the hospital, those are the people who should be getting them level of care recommendations and getting them services. But it's often that gap where they fall out. They're getting discharged from residential, from a hospitalization, and they don't have anything set up somehow. It's infuriating, but this is happening across the nation. Where do they always end up? They always end up back at their primary care provider. And that's where we're kind of that safety net of making sure that a primary care provider is equipped to assess, refer, handle even the most severe behavioral health crises. I mean, I've had primary care providers call us with a kid saying like, can I keep him from leaving the office? And I'm like, no, that's kidnapping in Virginia, but you can call 911 and have them respond to the office and tell them why you think they're unsafe in the office and to leave. So we can certainly help up to the absolute highest level of need, including like calling 911 to the office. So I hope that helps explain a little bit of our role in supporting, educating, and navigating crisis systems. So including like in and out of the hospital, but really only in that gap between connecting from having care and not having care, not having care, having care. We're not case managing through multiple levels of care. We're really just trying to connect each gap. Because ideally, if the system's working, like inpatient should connect them to PHP, PHP should connect them to outpatient, ideally. But it's when they fall in those cracks and then they end up back in primary care. That's where we are at that safety net for these families.
I know we're kind of coming. I answered a couple of questions. Folks had some questions about the workforce and, both increasing the workforce through other incentives. And absolutely, that is definitely a priority in Virginia as well. I think we're coming at the problem at like different perspectives and different angles to address the needs because it does take time to build up that workforce. But we've got to do both, and specifically to the question about whether care navigation eases some of the pain points from a mental health clinician shortage. I think one of the things that it does is it hopefully, and I put this in the Q&A, I hope it gets families to the right place faster and identifying the right resource so that hopefully a family is not kind of jumping around to find the right clinician or have families get frustrated in that struggle. And also, that clinicians are working at the top of their strength. They're seeing the right kids at the right time. I think there's a lot of, it's not a direct line to easing the care navigation, to easing the workforce situation, but I think that it's maybe part of the package. And I know we're running short on time, but I don't know if Julia or Kim, if you want to add anything to that.
The thing I always tell people is that we acknowledge that VMAP is not an upstream solution. We are a downstream, like where the rubber meets the road, where kids and families are today, where primary care providers are right now with a kid in their office. That's where we are. That's where we're acting. And so while we are aware that this is a result of many things further upstream that could be better, and we advocate for that, we are a downstream solution. So in some ways, there is a little bit of we know that that's a bit of a disconnect, right? We're not addressing things further upstream. But if we are connecting with primary care providers and helping them identify things faster, earlier, get treatment to kids who are mild and moderate rather than severe, we know that we're preventing future harm. There's really good research and evidence that if we don't treat pediatric depression, they're more likely not only to have more severe depression in adolescence, but lifelong. Same thing with other things, like if we identify developmental disorders and autism earlier, get speech therapy in there faster, we know that the investment in that is a lifelong impact for that individual. So we're not just thinking like, downstream. On an individual scale, the benefit is tremendous for these kids, and that's where we are thinking and acting, hopefully. But system-wide, yes, we are a downstream solution. We are connecting with where the pressure and the friction is now today. There are initiatives in Virginia to work further upstream from that to improve workforce and to improve capacity in the system and improve efficiency within the systems, definitely. We also do really take a lot of pride and we cultivate relationships. I mean, part of this is having licensed mental health people who are all practitioners. Like none of us are macro practice kind of people. We were all and still are kind of like connected into our practicing communities. We're all from these pediatric serving institutions right here. So we are all very connected still with the practice world, and we have connections and colleagues in all these worlds. So when we are able to best place a need with the right program or the right clinician, eliminating any friction or wasted steps or wasted intakes along the way and get them right to what they need effectively and efficiently, that takes hopefully some burden out of the mental health system as a whole and is more satisfying for behavioral health providers. So we know that when we have a better sense of what kind of problems and diagnoses they like to work with, what kind of families they're most effective with, that we can refer those over to them and feel satisfied. It's good.
Thank you so much. I really would love to see this replicated in other places because it is so needed. And I know we go to our pediatrician for my youngest kid's meds, so it would be very helpful to have something like this to help with that navigation. So thank you again, Rachel, Kim, Julia, for sharing your time and experience. And for everyone else who attended, I hope that you got some really good information out of this. All the resources, of course, you can still get on this platform, and this has been recorded. Our next session is going to start in 30 minutes, and we're going to hear from a keynote speaker, Dr. Tanisha Foster-Freeman, who has been a colleague, and she's an excellent speaker. She's going to explore the individual, interpersonal, and organizational factors contributing to mental health disparities among Black and Brown youth and young adults. So she's going to share some actionable steps to foster caring and equitable systems in collaboration with our communities and aiming to eliminate disparities and to create meaningful change. So I hope that you will join us again in 30 minutes for the keynote. Thank you again for all being here and for sharing your information.
Thank you, everyone.